Bismillahirrahmanirrahim. In the previous two lectures, we studied the two very important forms of gastritis, H. pylori associated gastritis and autoimmune gastritis. Now, today we'll discuss the various complications that can arise as a result of chronic gastritis. The complications are being displayed on your screens: peptic ulcer disease, mucosal atrophy and intestinal metaplasia, dysplasia, and gastritis cystica. By far, the most important is peptic ulcer disease, and it needs special attention. And you people will come across a lot of patients during your routine clinical practice of this specific peptic ulcer disease. Peptic ulcer disease, which is also written in abbreviation form as PUD, it is basically chronic mucosal ulceration. So, because it arises as a result of chronic gastritis, and at the name, it is evident that there occur ulceration. So, it is a chronic ulceration that affects either the stomach or the duodenum. Usually, peptic ulcers, they are very strongly associated with, when we talk about the epidemiology, they are very strongly associated with H. pylori infection, cigarette smoking, and third very important cause is NSAIDs, non-steroidal anti-inflammatory drugs. Peptic ulcer, it can occur in the antrum or it can occur in the duodenum, and the main cause they are already mentioned to you people: H. pylori, NSAIDs, and the cigarette smoking. And peptic ulcer disease, it is usually associated with increased gastric secretion, especially when we talk about the peptic ulcer disease as a result of H. pylori induced infection. And on the other hand, the H. pylori induced peptic ulcer disease, it will cause a decreased secretion of the bicarbonate in the duodenum. So these are the two important features that are related to H. pylori induced gastritis leading to peptic ulcer disease. So increased gastric acid secretion and decreased duodenal bicarbonate secretion. So talking about other risk factors of this peptic ulcer disease, we have some chronic obstructive pulmonary diseases like COPD, which can decrease the blood flow to the GIT, which can cause the hypoxemia and ultimately leading to hypoxemia of the mucosal epithelial surface, leading to ulceration. Similarly, various drugs, for example cocaine, NSAIDs, they are very important. Alcohol is important. Psychological stress, psychological depression, that can cause the peptic ulcer disease. Zollinger-Ellison syndrome is very important, and this Zollinger-Ellison syndrome, it can cause widespread ulceration, especially in the stomach, duodenum, and also in the jejunum. Certain viral infection, for example cytomegalovirus and the herpes simplex virus, they can also lead to the formation of peptic ulcer disease. Talking about the pathogenesis of this peptic ulcer disease, basically the main thing is there is imbalance between the mucosal defense mechanism. When there occurs the imbalance, any of the defense mechanism that is lost, various damaging factors which can arise as a result of chronic gastritis can lead to mucosal damage, further mucosal damage. For example, it can lead to ulceration. If we talk about the H. pylori, it can lead to increased production of acid, and it can lead to decreased bicarbonate secretion in the duodenum, ultimately causing the various complications of peptic ulcer disease and uh, morphology. When we talk about the morphology of ulceration, ulcer, what is an ulcer? Ulcer is a defect in the epithelium. So there is a continuous columnar epithelium in the stomach, and abruptly there occurs a defect. The place where there is a defect in the epithelium, that will be called as ulcer. Peptic ulcers, they are usually located in the lesser curvature of the stomach. They are also seen in the proximal part of the duodenum. When we talk about the lesser curvature of the stomach, the most common location, that is the body and the antrum. Usually the patients they present with the solitary peptic ulcer, only a single peptic ulcer, and that is seen on the endoscopic view. And the size of the peptic ulcer, that is quite small. It measures about 0.3 centimeter in diameter, and sometimes it can go more than 0.6 centimeter in diameter. Classically, if we describe the morphology, the gross morphology of the peptic ulcer, they are rounded in shape and punched out lesion, sharply punched out lesion, like if we have taken out something from its surface, and a defect is created, so that will be called as punched out lesion. It is a sharply punched out lesion. While on the other hand, if we talk about the gastric cancers, gastric adenocarcinoma, the ulcer that is seen in gastric adenocarcinoma, that has a heaped margin. The base, that is necrotic, and the margins, they will be hanging over the base and almost covering the base, so heaped margin. While in case of this peptic ulcer, punched out margin with a clear base, while in case of cancer, heaped margin that will be hanging over the base. That depth of the ulcer, it can vary, depending upon the severity of the disease, and if it is the ulcer is more deep, it can erode the underlying vessel and ultimately can result in the hemorrhage. And similarly, when the erosion is so much deep that it can ultimately lead to the perforation of the part of stomach or the duodenum. And if there is a perforation, that perforation, it is a surgical emergency. So active bleeding, active perforation, they are surgical emergencies, and they should be treated in the surgical emergencies. So this slide showing the various causes which cause the peptic ulcer disease. Just see the leading cause, that is H. pylori infection, followed by an NSAID use. Then comes a few other causes that are not shown here, especially the cigarette smoking, that is very important. So again, the causes, they are tabulated in, and this table can be memorized, because it can be asked, can list the various causes of peptic ulcer disease. So all these are the causes: common causes, uncommon causes, and the rare causes. And how we can prevent this peptic ulcer disease? We have to modify our diet. We have to uh, do modification of our smoking and drinking habits, avoid alcohol, as it is also haram in Islam. We should change our personality. Type A personality people, they are more prone to develop these gastric ulcers. So basically it comprises of three things: H. pylori infection, various lifestyle risk factors, and various drugs. All these three, they can lead to development of peptic ulcers. All these things, they have been discussed previously. What is the gross appearance, the microscopic, the microscopic features, they need elaboration here. Difference between a benign and malignant ulcer, that has been clarified, and clinical features will be discussed. If we talk about the microscopic features of an ulcer, uh, the epithelium will be continuous, and suddenly there will be a missing area. There will be an ulceration or eroded area of the epithelium, and that eroded area of the epithelium, uh, that will show numerous inflammatory cells, especially neutrophils. There may be initially there will be neutrophils, followed by other inflammatory cells like lymphocytes, plasma cells. Beneath the inflammation, beneath the inflammatory cells, we will find granulation tissue. We will find fibroblast. Within the granulation tissue there will be angiogenesis or blood vessel proliferation. The vessel walls, they will become thickened, and sometimes the vessels present beneath an ulcer, they can become uh, ulcerated also and thrombosed. Clinical features, they usually include nausea, vomiting, abdominal pain. That is a very consistent feature of these of the peptic ulcer. Similarly, if there is bleeding from ulcer, it can lead to chronic iron deficiency anemia. Ulcer, it can result in perforation. So all these, they are the clinical features of peptic ulcer disease. So this slide, it shows various common risk factors, and yes, one very important difference that is present in this slide is between the gastric ulcers and the duodenal ulcers. Gastric ulcers, in gastric ulcers, the patient, he or she loses weight, while in case of duodenal ulcer, the patient, he or she gains weight. Why it is so? Because in duodenal ulcer, pain occur 2 to 3 hours after meal when the stomach becomes empty. So empty stomach, it will lead to pain, and the patient, when he or she tries to avoid that pain by eating, will gain weight. While in case of gastric ulcer, pain, it occurs after eating. So patient usually, they usually delay their meals, they usually delay their food intake. As a result, the patient ultimately shows signs of weight loss. So these are the two important features of gastric and the duodenal ulcers. In duodenal ulcers, the pain occur empty stomach, while in gastric ulcer, the pain occur after taking meals. And in duodenal ulcer, the patient, he or she gains weight, while in case of gastric ulcer, the patient, he or she can come across weight loss. So these are the pictures of endoscopic views of gastric and the duodenal peptic ulcers. Clean base, white colored base, and sharply punched out lesion, no overhanged or heaped up margins, which are seen in case of cancer. A microscopic picture, the gastric mucosa is intact on the sides, and in the central part you can see an abrupt discontinuation of the gastric mucosa, and there is an ulcer base, and beneath the ulcer base numerous inflammatory cells are seen. Fibrosis is evident. A thickened blood vessel, thickened and thrombosed blood vessel, that is also seen in the periphery. Again, a view of ulcer, whether it is skin ulcer, whether it is gastric ulcer or ulcer in any part of the any other mucosal lining, the features, they will be same. So the chronic and the acute inflammatory cells and the few chronic inflammatory cells, they are quite evident in this picture. Another picture of ulcer, and if you look above this large blood vessel, that is quite sclerosed, just above it you can see a collection of these lymphoid cells, inflammatory cells, resulting in the formation of a lymphoid aggregate. So the same features which I initially told you, in gastric ulcers, the symptoms usually do not follow up consistent pattern, and eating sometimes exacerbates rather than relieving the pain. While in case of duodenal ulcer, the pain is more consistent, and patient is awakened at night when the stomach becomes empty, and pain that is relieved by food, but it again recurs 2 to 3 hours after meal. These are the complications. There is a very good table that is present in Robbins about the complication, which include bleeding, perforation, and obstruction. If we talk about initially about the bleeding, that is a very consistent feature and occur in about 20% of the population. It is the most common complication of the peptic ulcer disease, and chronic bleeding, it can lead to iron deficiency anemia, and sometimes the bleeding can be severe when there is erosion of some large caliber blood vessel, and that can ultimately lead to death. If we talk about the perforation, that is not that much common feature, but it can occur and can cause severe abdominal pain and is a surgical emergency, and if not treated appropriately can lead to death of the patient. Obstruction or the stricture formation, it can occur especially when we talk about the gastric outlet or the pyloric canal. Though it is not that much common, but it can occur. It is less common even as compared to the perforation. Obstruction, it can also occur when there is severe inflammation of the pyloric canal due to the gastric ulcer or the peptic ulcer. Uh, Patient usually present with the nausea and vomiting, and the reverse peristalsis they can be seen. So obstruction is another consistent feature, and when we talk about the perforation, a patient can develop peritonitis also along with the perforation. So that is also a complication of peptic ulcer disease. So you can see these NSAIDs which are causing the ulceration in the stomach, and the stomach is weeping. And on the other hand, we have this bacteria H. pylori that is sleeping, or that is almost dead due to the use of proton pump inhibitor, due to use of antibiotics that are uh, included in the regime for the eradication of H. pylori. Intestinal metaplasia. Intestinal metaplasia, it is a very important complication of the chronic gastritis and can result in loss of the parietal cell mass. So now how will we label that there is intestinal metaplasia? A single important feature is the presence of goblet cells. When there is presence of goblet cells in the stomach, it is intestinal metaplasia. And the presence of goblet cells, the presence of intestinal metaplasia, it carries an increased risk of the cancer, similar to the esophagus, the lower end of the esophagus, where the intestinal type of the metaplasia can result in the development of adenocarcinoma. Dysplasia, it can occur especially due to free radical injury, and can ultimately cause the various mutation. And when there occurs mutations, it can result in pleomorphism of the cells. There occur variations in the epithelial size, shapes, hyperchromasia, and nuclear enlargement. Gastritis cystica. Gastritis cystica, that are usually associated with trauma, and when repeated trauma occur, it can result in the formation of these cyst-like spaces. But what are the reasons of the development of these epithelial cells? They are not that much clear. So repeated trauma of the gastric mucosa can result in the formation of these cystic spaces, and these cystic spaces, they are called as gastritis cystica. So this was the lecture, a brief lecture about the various complications of the chronic gastritis. Top of the list being the peptic ulcer disease. Then comes the intestinal metaplasia, which carries an increased risk of carcinoma. Similarly, dysplasia, that is itself the pleomorphism of the cells and result in the invasion or and development of carcinoma. And last is the gastritis cystica, in which there occurs the formation of the cystic spaces in the gastric mucosa, and these cystic spaces, they are formed as a result of trauma. So in the next lecture, we will discuss a very important topic, that is the gastric polyps.